He has also played a very important, this department has played a very, very important role in capacity building for the nation, and also training not only doctors, the young trainees, the undergraduates, postgraduates, but also helped in training various paramedics for achieving the best possible treatment and results during this, once this program has started. Also, this center has the first skin bank in the public hospital in North India. Today we are having this program on the face transplant program, and I think it's very important that the media serves a very important role in spreading the awareness so that people are registered for this program to take advantage of this initiative by this department. In addition to that, this program is only possible because we have a huge team which is backing this program, which is responsible for its achieving the optimal results. We have the Department of Anesthesia, Pain Medicine and Critical Care, Department of Anatomy. We also have the Organ Retrieval Banking Organization members, the Department of Otolaryngology, Pathology, Plastic, Reconstructive Surgery where it's done, as well as Transplant Immunology. So they all would be addressing you and telling you about this program. So the flow of this press meet would be that first we would be briefed by the Chief of Burns and Trauma, Dr. Manish Singhal. We also have with us Dr. Indraneel Sinha. He's a Deputy Chief of Plastic Surgery in Harvard Medical School. Let me tell you that in the United States of America, 30 face transplants have occurred, and 10 have been done by his team alone. So he would be spreading here, telling us about this, what is face transplant, what it entails, and what all we should do to achieve the best results. And this would be after the briefing by the senior doctors here. There would be question answers by the media, followed by individual bites. Dr. Manish.
So Burns and Plastic Block, as Madam said, we were operational in 2021, and after in last 5 years we have done reasonable work. So we already have surgical innovation laboratory, skin bank. We do a lot of research. We are Center for Excellence for Research by ICMR. We do more than 250 complex microsurgical reconstructions every year. We do extensive work on acid attack victims and post-burn deformities. We do more than 8,000 procedures, which include all type of complex procedures, congenital anomalies, as Madam said. So with that experience, also we were critically important team members for very, very complex surgeries like craniopagus. We all know about the story of craniopagus. The plastic surgery department is involved. The pyopagus, thoracopagus. So there are various conjoined twins which we have participated in past. And also we recently, a mountaineer was seriously ill and he was with us for more than 200 days. And he also walked away out of this department. And we do couple of reconstructive surgeries for acid attack victims. But now there are several patients which we feel we are not able to address their needs. Nowhere near, even after 10 to 15 surgeries also, ultimately the result is not something which we want to achieve or which the patient wants to achieve. And I'll just show you a few examples. Something like this, very complex, more than 10 to 15 surgeries have been done and we are nowhere near normal. So now what is the solution for these? So we of course have to, so this is the origin of facial reconstruction, started from India, then in World War it developed. So with these patients, possibly the face transplant is only the solution which we can offer to them. Of course, it has lot of challenges. It is, I must say, I'm not very sure, but I feel it is one of the toughest and the rarest surgery which is performed across the globe. So with this background, it is extremely difficult. It was very difficult for us to even think of starting this procedure, but we feel now this is the right time. We can not only to these patients which come to us, but also those many who have not come to us and who want this type of reconstruction. So what I want to focus is, in spite of the very advanced reconstructive procedures we know, there is no solution which we can offer to them. So the aim of face transplant, basically face transplant not only aims to give the aesthetics. If you see in all these victims, the aesthetics is not the primary concern. The primary concern is that even they cannot eat food, they cannot talk properly, they cannot breathe properly, they cannot move their eyelids, they don't have any facial expression, and they have extreme pain due to contractures, due to various procedures. So with these patients will definitely benefit with something which is known as face transplant. More than 80 have been performed all over the world, and primarily it is done in US, many countries of Europe, especially France, Spain. In Asia, what we have seen by our understanding is Turkey and China have done face transplant, but it is not been planned in India as of now. So what do we take in a face transplant is basically the full skin. Of course, some patients may not require the forehead skin or one side skin, but what we harvest is full skin, major blood vessels which we can unite with the neck of the recipient. We also take maximum possible nerves, because ultimately the sensation will come through nerves. So nerve harvest and joining them is an extremely important thing, and as we commonly do these procedures by our experience, so we are very sure that technically we are quite sound in performing these procedures. But the challenge is not only the surgical technique, but the challenge is many challenges are much more, which you will see in the coming slides. Sometimes we can take bone also, but then again it is a challenging procedure to take bone, but you can take bone also with face transplant. So indication, as I said, it is severe disfigurement, loss of critical structures, loss of facial function, multiple unsatisfactory reconstructive surgeries. So it is not the first thing which we will do for any patient. It is after the reconstructive surgeries, multiple reconstructive surgeries don't give us the result what we want to give, we resort to something like face transplant. So there are definitely some contraindications: unstable patients, cancer, non-compliance. So what we heard in China is that the person does not follow up properly, did not follow up properly. So it can, for a non-compliant patient, this can be a disaster. And anybody having a significant psychiatric disorders, as I said, it is not only for aesthetics. So if somebody is just trying to improve the looks after the procedure, this is not the procedure which he or she should resort to. Now, how do you select? So we need a committed patient, because immunosuppression is lifelong. It is just like kidney, it is just like heart. So it is, the immunosuppression is lifelong. The person should be accessible to medical surveillance. So in the initial 6 months, possibly he has to come to us twice a week, and then later on also the follow-up has to be very it is very robust follow-up which is needed, and of course no history of malignancy, and psychiatric screening is extremely important. So as madam said, it is a very multidisciplinary team which is required for this, and we have spoken to everyone, and all of them have extreme experience in doing many transplants which are first in country, like cardiac transplant, pancreas transplant, renal transplant. So we have enough experience, and so if I just try to say that if we get all the transplant experience with us, and if we put all our surgical experience, it looks like that we can do it. Of course, there will be a lot of challenges from the patient side and other side also, but technically we feel that after talking to everyone, we can definitely do it. So all these teams will be on board. They are on board, and definitely their team effort will be very important. So why it is important is basically not only for surgical steps and patient selection, but intraoperative, postoperative, long-term rehab, and the transplant coordination. So the stages are technically there are 2 stages. One is the harvest and one is the placing of the graft. So both requires approximately the first one requires 8 to 12 hours, the second one requires 8 to 12 hours. But as we have speaking to Dr. Sinha, sometimes during the application of graft, the person gets sick, and sometimes we have to do the surgeries in two pieces also. We take the patient back to ICU, patient comes back after 12 hours. So sometimes this may land up till 36 hours also, depends upon that. So this is what we do. Basically it consists of harvest from the donor. So the donor has to be brain dead donor, as it is for other organs, and the face harvest will start before the vital organ, that is the heart. So after once the face harvest starts, then only rest of the organs can be harvested. And of course, a lot of counseling is required on the donor families also. So challenges, surgical challenges, complex vascular and nerve anastomosis, lifelong immunosuppression, ethical concerns are extremely important, and I must say that it is more difficult than kidney and all because it requires color match also. It doesn't require only the HLA match, the blood group match, the tissue match, but it also requires color match otherwise. So to get a right recipient and right donor is extremely difficult with so much of variation in color, so it requires color match also. So we need a huge, huge means at least 30 to 40 people, recipients who are ready before we can harvest a face graft, because then we can choose which is the right candidate to take the face, and then we have to call 4-5 and then the procedure get done. So the recipient registry becomes very, very important for these type of procedures. The rehab is very long, and rejection is something which is not very uncommon, it is very common. So rejections are basically three as with other transplants: the hyperacute, which is immediate; acute, which is after few days; and chronic is after in years. I think chronic is after a month. I don't know the definition. Chronic is after some time. So all the three types of rejections are common, but our nephrology team and immunology team is very competent to handle these type of rejections because they see them routinely in kidney also. So we believe that we will be able to handle these type of rejections. And outcome, basically the outcome is, apart from the skin, the outcome is sensory, that is the sensation which starts coming in 3 months, and the motor comes after 6 months. So motor means the movement, the sensation means the facial sensations, and motor is very important because the facial expressions and the facial dynamics, facial movement, lip movement, other movements will usually return in 6 months. So our initiative, so I went to meet Dr. Sinha 6 months back in Boston, and we had some discussion at that time. And now during his visit, we did a lecture, we did a lot of discussions, and we spoke about collaboration from them because their unit has done more than 10. Dr. Sinha himself has been part of more than 5 transplants, and definitely his experience and our discussion will go on for next 2 days. So it has helped a lot for us to understand that what are the intricacies of this particular procedure. So he's sitting and he will speak after me. So we did a cadaver dissection workshop, and we did a harvest just to understand that what surgical steps are required. And next picture is little graphic, so you can decide. So this is what we harvested yesterday, the facial skin. If you see carefully, we harvest the lips and we harvest the complete face is harvested. And if you can see these 2 vessels which we joined with the recipient to make it, to give blood supply to this. So future roadmap is to develop institutional protocols. Of course, we will get guidance to develop multidisciplinary team, and we expect that team will consist of maybe 125 to 150 members, all knowing their roles very well, and all should be able to fit in whenever somebody is not present. Ethical issues are very important. International collaborations we have to look for, not only with Harvard but with maybe other institutes also, and the licensing requirements. And with this, I'd like to thank you very much. Thank you. Thanks a lot.
So it's a pleasure to be here. Met Dr. Sinha in Boston a few months ago, and then to be able to come here now and to be at AIIMS, where I've never been invited before, has been so special. I was born in India, and to come back to the top institution in India, I can't begin to tell you how wonderful of an experience that is. I'm currently the Associate Chief of Plastic Surgery at Mass General Brigham, and as a professor or associate professor at Brigham Women's Hospital, I've been a member of the face transplant team now. I've been a resident there and a faculty member there, and I've been there for 20 years. And so overall, as a resident and faculty, I've seen 10 face transplants, and in the course of my time there for the last 5, I've been one of the lead surgeons. And so here you can see a picture of how the operating room looks. I'm somewhere in the back there, I don't think you can see me. But it really is a team effort. There are surgeons involved here from transplant surgery, plastic surgery, and ENT that are all scrubbed in at any one time. And as Dr. Sinha mentioned, that these operations last anywhere from 16 to 24 hours. So we take turns scrubbing in and out, and it really is a team effort. And you're just seeing a snapshot here. So what you're not seeing is the months before. We've had multiple huddles where we've talked about the patient in conferences. We've had cadaver dissections, so we know exactly what we're doing for each patient in terms of the harvest and as the donor site. And then afterwards, we have multiple conferences. We see the patients together. And that's really the dedication to make this go right in terms of taking care of the patient appropriately. So then the question, of course, becomes in terms of having limited time, limited resources, why do we do this? And the reason we do this is because it can really be worth it. So this is patient Robert Chelsea, and his story is reported in Time magazine. And this is one of the transplants that we did at the Brigham in 2019. I did this with Dr. Pomahawk, and Dr. Pomahawk was the lead surgeon on this case. And what you'll see is that Mr. Chelsea had, I want to say 15 or 16 operations prior to space transplant, and you can see with this 15 or 16 operations, the outcome he has, which is the picture that you see on the left, is not a reasonable outcome. He can't open his mouth, his eyelids don't close completely, and his appearance, we don't do this for appearance, but his appearance is not really acceptable for him to go outside. He looks very conspicuous, and he has a tremendous amount of pain as well. And so to have 15 or 16 operations and to arrive at that state, and then to offer him one operation where he can have a much more acceptable outcome, and then to have his pain decrease significantly, to have that much of power with one procedure, if we can do that for people, I think is very much worth pursuing. And it's not without risk, but it's in very key centers that we can do something like this. So it's up to those centers to be able to offer that to our patients who need it. And on the left, I just mentioned some of the people along with plastic surgery that were involved, including ENT surgery, transplant, nephrology, psychiatry, physical therapy, and then of course the OR staff and nursing staff who donated so much of their time to make it work for these patients. And I think I'll just stop by saying, or I'll leave by saying, I think that's why AIIMS is uniquely situated to be able to offer something like this in India. Talking to Dr. Singhal for the last 3 days, as well as our conversations in Boston, and meeting all the residents here, and then meeting all the heads and departments for all the other specialties that I mentioned. Without that infrastructure, you can't offer this care to patients because it's not simply one operation and you're done. The preoperative care and the follow-up care, there's so many facets that you have to really make sure is covered to have an impactful and meaningful difference to their lives. Without being able to offer all of that in one center, you can't do this procedure well. And I think that this is probably one of the only centers in India where I can see being able to have all of that in one location and being able to do this procedure not only technically, but to have all the ancillary care that you need as well along with that. So I'm very excited to work with the team here as they develop this in the future, and hopefully we can offer this for Indian patients soon. Thank you.
One patient of cardiac transplant who completed 25 years healthy and surviving.
Thank you. It's 1970s, that's much before I joined. And our earliest survivor now is 47 years with the same kidney, and he's doing very well. Total we have done 3,700 so far, and about 3 to 4 a week. So we have been doing transplants since quite some time. Just briefly about transplants, as shown on the slide, in 1954 the first kidney transplant was done between twins at Brigham's, Boston. That was before the era of HLA as well as DNA profiling, so that you could not be sure that they were twins. So at that time, skin grafting was first done from the donor to the prospective recipient in the twins to prove that they were twins. Just because someone looks same doesn't mean that he is genetically a twin. So this was what was done in Boston at that point of time. Of course, now, so why I'm saying this is that skin is one of the most immunogenic organs, so one has to be extremely careful. And that's where I think the HLA team is very important, and I'm sure they would do a wonderful job in helping me out. Coming to the immunosuppression, we use the standard triple drug immunosuppression consisting of steroids, tacrolimus, and mycophenolate mofetil. I think the same thing would be used here, and of course we have a lot of experience with that, and we can help out with providing the therapeutic drug monitoring of tacrolimus because we have it in house. We can do that. We can help you out. As mentioned, rejection is an important issue, and with the kidney things are simpler because dialysis is there. Here, of course, it's chronic rejection. I think things would be difficult. He was mentioning about chronic rejection. The definitions have changed slightly over the last few years. Acute is after 7 days. Within 7 days is hyperacute. Then is acute. Earlier, chronic was said after 1 year if you have a gradually deteriorating renal function. I'm talking about the kidney. But now with histology, it is felt that even at 6 months' time, one can pick up subtle changes of chronic rejection. That's how it is in the kidney. I'm not sure about the skin part. Apart from rejection, of course, infection is the other major thing which one has to be very careful about, and our patients are very much prone for infection. The drug toxicity, tacrolimus itself is toxic, and that's why it can cause nephrotoxicity, which is a double problem for us. And many of non-renal transplants also subsequently develop kidney failure. In fact, significant number, 10 to 15% of disease donor transplants are actually non-renal who have had either cardiac or other transplants and then develop renal failure. So we have to look after the kidneys of all these patients very well. Post-transplant diabetes is another thing one has to take care of. So, and of course, sometimes necrosis of the femur. We have newer drugs now, and we have experience with the newer drugs as well. I'm not sure if they have been introduced in phase transplant, but then there is the mTOR inhibitor, sirolimus, and there is belatacept, which we have also been using. So I'll be very excited, and I wish them all the best, and we'll provide our best support. Thank you very much.
Thank you, ma'am, for the opportunity. So I'm Dr. Preeti, represent there will be social withdrawal, which in turn sometimes can lead to poor coping pre-transplant assessment to rule out these poor outcomes, both in terms of medical and the psychiatric part. Transplant clearance for kidney transplant patients, bone marrow transplant patients in surgery, which will require such long as there is a higher risk of delirium. So the psychiatric role of one-time treatment, and end of the treatment, the person will have to keep on taking.
No, there is no. We are the first one to, I think, prepare properly. Of course, there are a lot of challenges, right from licensing to, I think the training part is little, we can cut short the training part, but then the recipient registry and the license is something which is non-negotiable. So that will be the biggest challenge to find the right person, because once you find the right person, then we have to do the transplant analysis. Am I audible? The transplant analysis, the transplant analysis, and then we have to do the psychiatric clearance and many other clearances which will be required. So I think the first parallel step will be the transplant, the recipient registry, and one of the licensing requirements itself is the recipient registry, because they will ask that who all will benefit with this procedure. So I think after this particular meeting, if there is a good people know about it and people come forward to register, I think that will be the biggest advantage for us.
So अभी जो सर वर्कशॉप चल रहा है उसमें अभी तक सिर्फ only face का skin harvest किया है from a donor, like we saw in the picture.
So it is a surgical thing. Application is something which will be, we can apply on the another cadaver. That's not difficult technically, but we do these procedures daily in out. So very, very confident that we will be able to. We are joining fingers on almost routine basis, so we know how the joining does. But the removal has some critical steps which we wanted to discuss.
सर मेरा सवाल ये है कि इसमें लीगल एस्पेक्ट क्या है? जैसे मान लीजिए किसी का अगर कंस्ट्रक्ट करना है तो क्या किसी दूसरे से स्किन आप ले सकते हैं? क्या इसकी कोई लीगल एस्पेक्ट भी है? और दूसरा, आप लोग जो प्लान कर रहे हैं कब तक पहला सक्सेसफुल कर पाएंगे?
तो हाँ जी तो लीगल इसका कुछ भी नहीं है. लीगल के लिए तो ट्रांसप्लांट का पूरा लॉ है, और उस लॉ के अंदर आप फेस भी कर सकते हैं. और जैसे किडनी और हार्ट की जो रिक्वायरमेंट है, एक लाइसेंस के लिए एक इंस्पेक्शन होता है, वो इंस्पेक्शन में अगर लोगों को लगता है कि हम कर सकते हैं तो लाइसेंस मिलता है, फिर हमको रेगुलेटरी अप्रूवल के लिए जो मांगेंगे वो देंगे हम, तो लीगली कोई ऐसा प्रॉब्लम नहीं है। कब तक कर सकते हैं थोड़ा कॉम्प्लिकेटेड क्वेश्चन है, बट हमारा टारगेट है अगले 1 साल में इसको करने का। इसके लिए हमको और थोड़ा जैसे सर्जिकल टीम्स का सबसे कॉम्प्लिकेटेड था, बट नेफ्रोलॉजी टीम्स को भी आपस में बात करनी पड़ेगी, साइकियाट्री टीम्स को भी आपस में बात करनी पड़ेगी। तो वो जो कंसल्टेशन है, वो जो प्रोटोकॉल्स हैं, और सारे प्रोटोकॉल जैसे सर ने बोला कि जो प्रोटोकॉल हमारे यहाँ हैं किडनी ट्रांसप्लांट के और बाहर के बहुत फ़र्क हैं, क्योंकि इन्फेक्शन हमारे यहाँ इनको थोड़ा डिफरेंट टाइप का दिखता है। तो जब सब टीम्स का आई थिंक वो पैरेलल एक्टिविटी होगी तो उसके बाद हम कभी भी इसको कर सकते हैं। इंफ्रास्ट्रक्चर वाइज और स्किल वाइज हमको कोई प्रॉब्लम नहीं है, हमें बस चाहिए कि चीज़ों को जोड़ना एक साथ आपस में बस।
सर कॉस्ट वेरिएशन कितना होगा अगर ये एम्स में शुरू होता है और प्राइवेट में? अभी तक तो शुरुआत की है, लेकिन फिर भी कितना होगा?
इसका आंसर तो मैं नहीं दे सकता हूँ बिल्कुल भी। नहीं, मतलब आई डोंट नो how much do you charge for a face transplant maybe, but it's very difficult. I think as such the US has much more costlier medical system. Cost will be definitely huge once you need so much of teams working together, so much of preparation. For a private setup the cost will be huge unless and until they get some donation or some system. I must say that there must be very huge cost because it needs a lot of people to work together. Yes.
So AIIMS has already been doing a lot of these reconstructive surgeries in acid attack survivors, like Dr. Shivangi has been doing it. So I want to know, this will be different in the sense that this will be complete facial harvest and a complete transplant in that sense.
So I will not definitely say that acid attack survivors are the best suited candidates for this procedure. They are one of the candidates because as Dr. Sinha told and as I told, only after 10 to 12 surgeries we are able to understand that we can't benefit this patient much. So it will never be the first procedure. It will be after a couple of procedures when we feel that still we are not able to achieve what minimum the person requires to eat, to speak, or to live normally, or live at least apart from the looks. So it will so acid attack survivors, if they are able to eat properly, they can manage themselves. Possibly they are not the right candidates.
Then who can undergo this?
So there are multiple complex gunshot injuries, trauma conditions, which can be the right candidates, and electric burns is something which can be the right candidates. Of course, severe acid attack victims. So the pictures I had shown you, 2 of them were acid attack victims. One was 2 were acid attack victims or not, I don't know, but they had acid on them, and one was other severe burns, not due to flame burns. So there are many patients with these type of conditions, and I'm sure we don't know all of them, but we know now that how to screen them, how to work them up, and whenever somebody will come forward, we have that work up with all our teams, and then we can decide whether he or she is a suitable candidate or not.
Sir, Anjali Tisai from Thinking. Sir, face transplant में gender और age कितनी मायने रखती है और patient ठीक कितने वक्त में होता है?
Gender का they are asking what do we need a gender match also, I think, of course.
Yes, we need a gender match.
So the gender match is of course very important because and the color match is also important. Now healing is very different. As sir told that skin healing is something which can occur, not a problem, but then the rejection is something which is anti-healing, which keeps on happening. As madam told that that patient had 9 rejections. What is the average rejection what a face transplant has? I think more than 80% have some sort of rejections.
So within the first year, there's a 95% or above rejection rate. So rejections happen constantly. It's constant.
And they are managed with medicines then. So it is a very constant struggle.
Sir, इस surgically कैसे patients eligible होंगे, कैसे नहीं, क्या इसको लेके भी कोई direction है?
I think severe facial disfigurement, when you cannot perform the daily facial functions like eating, speaking, blinking, can't breathe, I think this will be the most important indications.
So for this you would require a very robust donation program and education of the public regarding brain death and then donating. So how do you plan to do this?
So that is the other side of the donation, that is who will give the face.
Yes, that's it.
But I think that is definitely a big challenge for which we have Orbo with us, and the counseling is very, very important because people can give organs, but somebody who can give heart, kidney, liver, lung can also give face. Means it is not that difficult for people who are actually interested in donations, but that is the second challenge. The first challenge will be to find the right person who will be benefited face. We see quite often those patients which come to our outpatient, but you have to understand most of these patients even don't come out of their homes. So they are not coming because most of them have already gone 10 surgeries, 12 surgeries. And another challenge is the availability. Means we can, as AIIMS, we can function only in Delhi NCR possibly, where person can come to us and go back home and come for regular follow-up to start with, till we have programs everywhere else. So there will be huge challenge in finding the right recipients also, I believe.
Yeah, I
Sir,
think
वो
the
अभी
media
आपने
can serve that.
Yes.
I think the
अभी
media
आपने
can
मैं
serve
अनूप
that.
हूँ दैनिक जागरण में। अभी आपने कहा कि हम ये देखेंगे कौन अपना चेहरा डोनेट करता है, तो क्या चेहरा बदल जाएगा?
सर मेरा भी सवाल यही है कि आइडेंटिटी क्राइसिस।
अभी आपने देखा एक सर ने पिक्चर दिखाया फेस ट्रांसप्लांट का, तो आपको कितना बदलाव लगा? अगर कलर मैच नहीं है और हड्डियां आपकी फेस की हैं, तो जो फेस जो ड्रेप करता है वो ऑलमोस्ट थोड़ा तो बदलेगा डेफिनेटली, इसमें कोई डाउट नहीं है, बट कलर मैच होने से और बोनी फ्रेमवर्क होने से चेहरा तो उसका जो आज का चेहरा है वो तो बदल ही जाएगा, जो पहले था उसका इंजरी से पहले का वैसा चेहरा तो कभी नहीं आएगा जैसा उसको इंजरी से बहुत पहले था।
थोड़ा चेंज होगा।
नहीं, वो तो पूरा ही चेंज होगा। मतलब
सर आइडेंटिटी क्राइसिस को कैसे मैनेज करेंगे?
वो मैडम ने बताया देयर आर मेथड्स टू मैनेज दैट साइकियाट्रिकली। जब पूरे वर्ल्ड में 80 ट्रांसप्लांट हुए हैं और लोग मैनेज करते हैं, तो आई एम श्योर हमारे यहाँ भी उतना टैलेंट है मैनेज करने के लिए। बाकी मैडम कैन टेल दैट हाउ डू दे मैनेज द आइडेंटिटी क्राइसिस।
So actually when जो previous studies है, जो literature में भी है, usually जब उनका face still दिखता है after surgery, most of the patients में
आज शशांक को बोलो।
डॉक्टर मनीष, आई जस्ट वांटेड टू नो कि ये जो पर्टिकुलर आप लोग फेस ट्रांसप्लांट के लिए आपने वर्कशॉप की है, क्या कह सकते हैं कि एम्स में जो है फेस ट्रांसप्लांट कब से शुरू हो जाएगा और क्या आपके पास इस तरह की डिमांड्स आती है?
इस तरीके की डिमांड्स तो नहीं आती, क्योंकि हमारी तैयारी नहीं थी, तो हम ऑफ़र भी नहीं करते थे। बट ऐसे पेशेंट्स ज़रूर हमारे अक्रॉस आते हैं जो कि फेस ट्रांसप्लांट से इनको फ़ायदा होगा। उम्मीद ये है कि अगले 1 साल में हम काफ़ी तैयारी कर लेंगे शुरू करने की। बट सही आदमी को पहचानना जिसको ट्रांसप्लांट चाहिए और एक डोनर मिलना हमेशा के लिए चैलेंज रहेगा ही रहेगा डेफिनेटली।
सर, भारत में अभी तक फेस ट्रांसप्लांट हुआ है या नहीं हुआ है, ये थोड़ा क्लियर कर दीजिए।
इंडिया में कभी नहीं हुआ है, मेरी नॉलेज के हिसाब से इंडिया में कभी कोई ट्रांसप्लांट नहीं हुआ है फेस का।
तो क्या हम कह सकते हैं कि एम्स जो है
पहला अटेम्प्ट करने की कोशिश करेगा जी।
एक लाइन
एम्स जो है पहला ट्रांसप्लांट अटेम्प्ट करने की कोशिश करेगा, उसके लिए हम तैयारी कर रहे हैं।
सर, इसमें कॉम्प्लिकेशंस और चैलेंजेस कितने होंगे, क्योंकि पूरा टीम एफर्ट चाहिए?
सो कॉम्प्लिकेशन एक तो सर्जरी के हैं कि ठीक से सब वेसल जुड़ जाए, ब्लड सप्लाई आ जाए और फेस सर्वाइव कर जाए, पेशेंट सर्वाइव कर जाए। उसके बाद जब सर्वाइव कर जाता है, उसके बाद जो नेक्स्ट चैलेंज होता है रिजेक्शन का होता है, क्योंकि जो एंटीजन है स्किन के वो कोशिश करते हैं कि उस फेस को रिजेक्ट करते हैं। उसके लिए हम इम्यूनोलॉजिकल ड्रग्स देते हैं, स्टेरॉइड्स देते हैं, और ये चैलेंज कई सालों तक इनफैक्ट कह सकते हैं तो लाइफ लॉन्ग पेशेंट को फॉलोअप में रहना पड़ता है।
सर, अगर चैलेंजेस ज़्यादा है तो ऑब्वियस है कि अगर प्राइवेट अस्पताल में अभी तक हुआ नहीं है, लेकिन बाहर अगर होता है तो कॉस्ट भी ज़्यादा होती होगी, तो एम्स?
बिल्कुल, तो ये सब प्रोसीजर जैसे कि एम्स से किडनी ट्रांसप्लांट शुरू हुआ, हार्ट ट्रांसप्लांट शुरू हुआ, लेकिन जब डिमांड बढ़ती है और जब नीड बढ़ती है और एम्स तो सारा काम अकेले नहीं कर पाएगा लॉन्ग रन में, तो जो भी पेशेंट की अगर सरकार को सपोर्ट मिलेगी या और भी कई सारी और संस्थान आज पेशेंट को सपोर्ट करती हैं, तो कॉस्ट बियर करने के फ्यूचर में बहुत तरीके हो सकते हैं।
Sir, as you have been doing face transplant already, in which country you have already done and how much challenges it involved? If we talk about India.
Yeah. So I've only done face transplants in the U.S. I've personally been involved in 5 of them. The challenges involved, they started the pre-op time. and then they extend through the operation itself and post-operative. And there's unique challenges in each period. In the preoperative period, it's making sure that the patients understand how much effort it will require on their part. And then from the part of the practitioners, it's getting the whole team together, making sure everyone knows what their role would be, and coordinating the team so that when the time comes, everyone's ready. During the operation, it's a very long operation, and also it's the same thing, that making sure everyone knows what their role is, the whole team is working together. And then post-operatively, the patient requires a lot of monitoring. Initially, they're in the intensive care unit, and rejection, which can happen and threaten the transplant, is a very real concern. So they are very carefully monitored. The first month, biopsies almost weekly, and then even after that, they're constantly contacted. We're checking in all the time to make sure they're doing okay. And it's not just a single plastic surgery effort, it's by the entire team. And if there's any concerns, we relay it to the other surgeons, we relay it to the nephrologist, the pathologist. And so without the whole team working together, these patients don't do well.
So what are the challenges involved?
The challenge involved in the operation itself is making sure that we are harvesting all the nerves, connecting them properly, so that it's not just that the transplant lives, but the patient gets a functional benefit from it. Afterwards, it's not just the rejection medications to make sure that the transplant lives, but all of the effort that the patient requires to work with the physical therapist, the occupational therapist, to make sure that they gain function back from the face, and it's not just the transplant makes it look better, but it functions properly.
Sir, as you are giving the training to the Indian doctors as well, how do you see that, when India is going to be able to do the face transplant?
It's a very good question. I think that it's not a single training that we know that. It's going to be multiple times where they've gone through cadaver dissections 4 to 5 times. And I don't think it's me making that assessment alone. I think it's when they say they can do the dissection and they feel comfortable. I think I can look at them and say, okay, it looks like they're getting more comfortable, but I think it's when they go through the dissection, they don't need my assistance with anything, and they say, I feel comfortable getting out all the nerves and the blood vessels without any assistance at all, and I think that's when they're ready to do it technically.
Sir, how much costly it is in other countries like US you mentioned?
So in the U.S., cost is a very difficult thing to estimate. When I mentioned the procedures that we talked about, it was done with our time entirely being donated. So cost estimates are very difficult to say. All the costs that come were entirely from the hospital stay side. So there was the hospital stay and some of the medications, but the reason I can't give you a good cost estimate is in the entirety of the time of the team was donated.
Sir, for face transplant, how much hours are required or days are required? How long we can preserve the face?
It's the faces that we've done at the Brigham, the majority of them have been intact for greater than 10 years now. We've had one patient that we've had to do the second transplant on, and that was at 9 years. And I believe we've had one mortality, and that was at 8 years. So the expected time frame is we're still learning, because many of these transplants are still in their relative young ages, but we expect more than double-digit timetables for the transplants.
Is this a part of a collab? Sir, ये जो एम्स में ट्रेनिंग शुरू हुई है, इससे लोगों को क्या फायदा होगा, और साथ में अगर फेस ट्रांसप्लांट करना है तो लगभग कितने टाइम तक जो है उसको रखा जा सकता है, अगर डोनर देना चाहे, और इसके लिए अभी एम्स कितना तैयार है?
तो अभी तो ट्रेनिंग चल रहा है। जो विदेश से जो डॉक्टर्स आए हैं वो हमारे डॉक्टर्स को ट्रेनिंग दे रहे हैं कि किस हिसाब से आप कहाँ तक काटना है, कितना काटना है फेस का, और उसको आपको कैसे उसको ट्रांसप्लांट करना है जिनका फेस में। तो ये तो सिर्फ ट्रेनिंग चल रहा है। ये ट्रेनिंग बहुत ज़रूरी है, क्योंकि जब आपको एक्चुअल डोनर मिलेगा जो कि तैयार है फेस डोनेशन का लिए, तो ये डोनर कौन होते हैं? ये डोनर वो होते हैं जो ब्रेन डेड है, जिनका सिर्फ मस्तिष्क या थिंकिंग कैपेसिटी नहीं है, पर बाकी उनका बॉडी काम कर रहा है। और ये वो पेशेंट्स होते हैं जो वेंटिलेटर में होते हैं। तो इनका जो परिवार है उनका सहमति से इनके अलग अलग ऑर्गन्स जो है ये हार्वेस्ट हो सकते हैं। इनका जब आप ऑक्सीजन निकाल देते हो तो इनका उसी टाइम डेथ हो जाता है। इनको खुद का सांस लेने का भी क्षमता नहीं होता है और उसमें उनको मदद चाहिए होता है। तो आप जब ऑक्सीजन सप्लाई नहीं उनको देते हो तो वो ऐसे ही वो काफ़ी ट्रबल में है, तो परिवार के हिसाब से वो वहाँ से हम लोग किडनी, लीवर, लंग, हार्ट, आँखें, ये सब हम निकाल के हम लोग ट्रांसप्लांट कर सकते हैं। पर हमारे देश में इस बारे में सामाजिक जागरूकता बहुत कम है। जो शरीर हम जला रहे हैं, जो शरीर हम मिट्टी में दफन कर दे रहे हैं, उस शरीर से इतने लोगों का भला होगा, इतने लोगों को नई ज़िंदगी मिलेगी, इसके विषय में जागरूकता बहुत ज़रूरी है। ये विदेश में जैसा जर्मनी में इस बारे में जागरूकता बहुत ज़्यादा है और लोग ज़्यादातर डोनेशंस में प्रोत्साहित रहते हैं। पर हाँ,
अभी तक लगभग विश्व भर में कितने ट्रांसप्लांट हो चुके हैं?
फेस ट्रांसप्लांट विश्व भर में करीब 80-90 तक हो चुका है और इंडिया में अभी ये पहली पहल है, जबकि ये फेस ट्रांसप्लांट होने का अभी 1-1.5 साल में फेस ट्रांसप्लांट हो सकता है।
सर, फेस अगर जो डोनर है उसका अगर फेस ट्रांसप्लांट करना हो तो कितने टाइम तक हम प्रिजर्व कर सकते हैं?
जैसे डॉक्टर साहब ने अभी बोले, जो हमें तैयारी सब कुछ रखना है, डोनर को तैयार रखना है कि, और हम लोग को जब खबर मिलेगा कि ये रिसिपिएंट है, तो डोनर का फेस के निकालने के बाद, फेस के टिश्यू निकालने के बाद मेरे हिसाब से 3 से 4 घंटा, ये 5 घंटा के भीतर उसको जो रिसिपिएंट है, जिनको फेस देना है, उनका फेस का टिश्यू उनको इसके भीतर उनको ट्रांसप्लांट करना है।
अच्छा सर, जो ये ट्रेनिंग है ये पहली बार एम्स में शुरू हुई
ये
है?
पहली बार शुरू हुई है।
तो सर, इसमें जो एक फेस को लेकर जो है ट्रेनिंग दिया गया है, वो फर्स्ट टाइम हार्वेस्ट किया गया है किसी पेशेंट का फेस?
फर्स्ट टाइम हार्वेस्ट किया गया है। उसके ब्लड वेसल, उनके नर्व्स, उनके मसल, उनके स्किन, किस तरह से हम उनको लेंगे, एक्चुअल जब कोई पेशेंट आएगा, ब्रेन डेड पेशेंट, तो उनसे हम कैसे वो टिश्यू लेंगे, जैसे वो हम जब उसको ट्रांसप्लांट करते हैं तो उसका नर्व सप्लाई रहे, उसका ब्लड वेसल रहे, तो ये पहली बार ट्रेनिंग हुआ है।
सर, ये जो ट्रेनिंग में फेस जिसका इस्तेमाल किया गया है, हार्वेस्ट हुआ है, तो परिवार को पता है कि इसके लिए इस्तेमाल?
हाँ, ये जो जहाँ से ये ट्रेनिंग हुआ है, ये देहदान का प्रक्रिया है डिपार्टमेंट ऑफ एनाटॉमी एम्स में, जो पर्सन्स खुद अपने जीवित काल में देहदान करने का इच्छा प्रकाश करते हैं, तो उनको बाद में जब उनका अंतिम श्वास के बाद उनके परिवार के लोगों उनको हमारे यहाँ खबर दे देते हैं और हम लोग ये प्रक्रिया जो है, ये प्रक्रिया देहदान का, इसको हम लोग पूरा करते हैं।